Good evening to all of you. And today we came across a very interesting case, uh, neurology case. And this short presentation is just to highlight the power of discussion uh, between my PDCC resident and myself, and how our residents, even though they may not be doing their PDCC, can be a great help in being the bridge between the clinical cases and the reports that you're making. So normally what we do is that we do our reporting, and then our residents, they enter the raw data of our AST on the WhoNet in real time, and they send me the PDF. If I am there or Dr. Devrath is there, they will send me the PDF, and then we customize those PDF and we make the final reports. I have shared many of the reports with most of you who have seen them before. So I received a PDF from a tracheal aspirate uh, from the WhoNet from my senior resident. So like I said, we customize them into three parts. That is the diagnostic stewardship component. First is to establish the authenticity, whether the particular bug is a true pathogen or not. Then what is the specific site and the antimicrobials that have been tested against it. So we include that in the antimicrobial stewardship component. What should be the doses? What should be the combination antibiotics if required? And the last part is the hospital infection and prevention stewardship component. So this was a tracheal aspirate from neurology inpatient that isolated a Acinetobacter baumannii and was unusually susceptible, which is not so common. And I was quite surprised also. But yes, we checked it on our MALDI. It was Acinetobacter. When you tried to establish a diagnostic stewardship, looking at the gram stain, there were occasional pus cells, occasional gram-negative bacilli. But again, this is not very conclusive that this is a true pathogen or not. So, but still, I decided to go ahead and make the report. And when I made the report, it was something like this. So, as you can see that uh, the SR had made a mistake of putting a ceftaroline, so I removed a ceftaroline, and I looked at the raw data, and that was ciprofloxacin susceptible. So I decided to report ciprofloxacin over there. But then, because this was an Acinetobacter, so we should avoid monotherapy with Acinetobacter infections. And in this case, I thought that let us give an attempt with the ciprofloxacin 750 milligram BD and cefepime 2 gram infused over 3 hours. So this was just the antibiotics which is suggested, but what was the antibiotic posology? And for those who don't know what the posology is, that how we are actually giving the antibiotic. In what sequence are we giving the antibiotic? And ideally, you should even write what are the diluents that we are using to dilute these drugs, and in what sequence are they be given. So uh, the first dose at 8 a.m. I thought that we can give ciprofloxacin 70 milligram BD IV over 30 minutes, followed by time gap of 30 minutes, because it's a concentration dependent kinetics, and so it requires immediate boost because it attacks the DNA gyrase. It's a genetic toxin for the bug. Then, of course, we can slowly infuse cefepime 2 gram over 3 hours. And because cefepime is given 3 times a day, so second dose at 2 p.m. will be only cefepime without Cipro. And the third dose will be just like the first dose, Cipro 750 mg IV over a gap of 30 minutes, followed by cefepime. So I felt quite happy with this report, and I sent this report to both my residents, Dr. Nikhil and Dr. Chitra. And just I asked them that in case you guys are around that ward, just go and look up and discuss if any clinical resident is there. So I got a call back from Nikhil. He said, there's some error in the report. Ciprofloxacin has been reported twice, one at resistant, one at susceptible. So again, it was my mistake. I recalled the report back, then I changed it. And I looked at the raw data again. It was definitely susceptible. So again, that Cipro resistant was a wrong entry. So which is why you should always check and counter check from your raw data what you have recorded on your daily AST, and then only send the reports. So when I discussed this case with Nikhil, This was a case from Neurology, 17, a female with epilepsy, admitted with aspiration following epileptic seizures. She landed with aspiration pneumonitis, that is Mendelssohn syndrome. She was put upon meropenem and clindamycin, and she was not responding. The lungs were absolute whiteout. The CRP was very high. The counts were high. The procal was 61. That's what the history Dr. Nikhil gave me, and we had a short discussion. So we thought that what can we give in this case? So we thought that if Miro and Clinda is not working, so is it a possibility that we could be having some anaerobes? But it did not seem like it's an anaerobic infection because it was a very heavy growth of Acinetobacter. So considering it was a lung infection, Cipro is a good choice. But and it was Acinetobacter, and what I have learned over the years, and even the literature also says that combination therapy is a wise choice for Acinetobacter and other nil fermenters. So we thought that okay, let us try Cipro and Cefepime as you had seen in the previous report. I suggested because it's a anti-DNA gyrase drug along with an anti-cell wall agent, so it will be a good synergistic combination. So why did I choose Cefepime? Because Cefepime has got a great spectrum. Now this choice of Cefepime I had given before I discussed the case with Nikhil. All right, so Cefepime is a good drug. It's got a good spectrum. It's got strong anti-AMC activity, but Acinetobacter is mainly the oxals, not the AMCs. And it's also a very good drug, and it's got great combination kinetics with enmetazobactam and zidibactam also, which is recently released now. The only downside of Cefepime is that it does not have a good anaerobic activity. It's not a very good anti-anaerobe. So he suggested that, sir, can we go in for Piptazo? Piptazo got good anti-anaerobic cover, but Piptazo is not a very wise choice for Acinetobacter. That's why it's not kept in the first, line of action. So we said that okay, let us forget Piptazo and Cefepime. Let us go with Cipro and Ampicillin, because sulbactam is a strong anti-Acinetobacter BLI, and I just kept it reserved. Uh, Ampicillin, I didn't want to give it as a first choice in my first report, so that's why I thought that let's try Cefepime. So ultimately, this is the final report that I changed, and Cipro was susceptible and Ampicillin was also susceptible, and the same report. And then this is the final treatment that we suggested again, that to avoid monotherapy with Acinetobacter baumannii infections. In this case, the treatment may be attempted with Cipro and Ampicillin as 9-gram TDS infused over 3 hours. So that's the standard dose that we normally follow for Acinetobacter, whereas sulbactam is the active component. Uh, and this was the final report that we said. So what I found this interesting because this was a very classical case where you cannot have a good antimicrobial stewardship until you don't have a good patient history, you don't have proper interaction, or you don't have a bridge like your residents or your PDC students or yourself. Also, there's no bridge or there's no communication, so there's a lot of gap between what you think and what really it is. So again, like I keep on saying that for nel fermenters, one may avoid monotherapy. And my personal experience, carbapenems do not work very well for nel fermenters. The target sites for the bug should be like in such a way that they are targeting the different sites. Preferably, one is time dependent, the other one is concentration dependent, having different PKPDs. They can be given differently at different sites. You should try to provide the antibiotic posology on the AST report as a part of the antimicrobial stewardship component. So how to give the drug, when to give the drug, and what sequence to give the drug, prolonged infusions, extended infusions, continuous infusions, all these things should be mentioned. And also the Y site incompatibilities must be observed. Any side effects, like in this case, if I had not known that this is a patient of epilepsy, I would have finally given Cefepime. But then because of this discussion, we changed from Cefepime to Ampicillin. and we should follow the PKPD profiles of the antibiotics to the core for maximum efficiency of the antibiotics. It might be in vitro resistant, but it might be in vivo susceptible only if we follow the PKPD kinetics of the antibiotics. So for this short presentation, thank you. For more updates on antimicrobial stewardship practices, please like, subscribe, comment, and share. Thank you so much, and good night. Thank you, Nikhil.